So at this time, we'll open it up to questions.
Well, so how do you integrate? How do you integrate? Private care going to the homeless. If they could go to a local, a Walgreens or a CVS, would that improve the care for homeless?
What she's done, the fact is, she's done, well, she has. She's done it, and she's done it privately, without government intervention or without government money.
So
Any change is going to come from the bottom up, and she's shown you how to do it, Rob. And I'm not saying that these pharmacies should do this. It's up to them. All I'm saying is there are 15,000 facilities out there that are not being properly used. 10% of their revenue comes from, or 80% of their revenue comes from 10% of their floor space. The rest is for selling pool toys, okay?
But do the homeless go into these facilities to get care?
They could.
They could. And is it a financial, is it a financial incentive that they don't have from the government? Or, what's the roadblock? What's the gate?
And I think that Dr. Morell is best to address that.
I think that the principles are on target of what you're getting at. So for homeless individuals, we use that as our case study, right? So for homeless individuals, when you go into Walgreens or CVS, sometimes the copay is prohibitive. So therefore, we set up systems where we have our own 340B pharmacy, and we have pharmacists who play a key role in education for our patients and work on adherence. And we have, for example, across discussion with primary care, behavioral health, and pharmacy, where we talk about, as a pilot, depression med adherence. I don't see that. I work in other healthcare systems as well, and I don't see that kind of discussion between disciplines like that in other settings. So, if you're asking specifically about the homeless and Walgreens and CVS, I think there's barriers, and that's why we do what we do. Could those centers serve other populations in ways? I think absolutely there's huge potential there. I don't know if you want to comment on that.
Yeah, I guess what I'd say about that, I think a population that's got mental health issues in particular is I hesitate to say it's a special case because they get carved out of all these discussions and they shouldn't, but there's clearly issues there. Do the chain pharmacies, are they going to usher these patients right out when they come in? Our patients, do they want to have discussions about depression, anxiety, mental illness over the counter with a pharmacist? It's a whole set of issues there. But if you take this just to the level of folks who are chronically ill, diabetes and the usual comorbidities, heart disease and so on and so forth, yeah, indeed. This is a huge part of the equation here. And let me just relate it to all that alphabet soup of quality improvement programs that are, as I say, increasingly linked to the way people are getting paid. At least right now, the way these are set up, and I think it's sort of the first generation of these improvement and reform initiatives. And by the way, we're not just talking government programs, we're talking about commercial payers that are doing this, and Blue Cross here in Massachusetts has been a leader in this and so on. So we're talking about private pay patients, basically. The first generation of the way this has been set up is it's very much focused on chronic disease and particularly diabetes and associated comorbidities. Now that's not necessarily where all the money is in healthcare and all the waste that you could wring out of healthcare could go. I mean, it's not dealing with traumatic injury, which causes a ton of money, and it's not talking about neonatal intensive care where there's a lot of money. But this is where folks are focused right now. And there you're talking about, managing conditions day to day. And it goes back to that slide, which is from when you look at retail pharmacy, there's just a whole lot more retail pharmacy out there than there is doctor's offices, and people, a whole lot more foot traffic through retail pharmacy than there is in doctor's offices. And that's a good thing for the system. But it's only recently that we've started to see some live attempts to try to integrate that and make that work. And so I think we're just on the cusp of that. So I'll put it in the glass half full terms. We're on the verge of discovering something about how to really use retail pharmacy. And I'll just add, one other factor. I mean, with the big chains, there is the nurse practitioner at the front of the store, and then there's the pharmacist at the back of the store. And we haven't seen yet how the front of the store and the back of the store are going to work together. Some of that, a lot of it is tied up with regulation, scope of practice regulation, and all of that, what you're allowing pharmacists to do, et cetera. But the need and the potential is there.
Dr. Bartel, you make a great point, and then I have a question. I know I'll talk to Brooks, but the 340B piece, and I don't know if a lot of folks Walgreens has entered into that arena pretty heavily in the last 5 or 8 years, and exactly what you said, how do we control these costs, and how do we reach out to those homeless individuals across the United States? I work with them closely on different programs, but they have a wonderful 340B pharmacy inventory system where we can bring these low-cost medications to these communities. So that it wasn't there initially, the retail sector was probably the last to fall asleep, but finally they're coming around now. They're realizing, let's put our pharmacists out in the center of the store, no longer behind the counter where they can't be, seen and obviously working with patients.
Well, there's so many things here. I mean, the 10 commonest drugs that are utilized in the United States are $4 a prescription in Walgreens, okay? The issue in this is what is the role of the pharmacist? And the pharmacists, at least the organizations, want to take a more active role. Now, there's been tremendous pushback from the American Academy of Family Practitioners. And I'm going to say something that I really believe, and I've written about, and it's been posted, and it's been commented on. I believe family practice is a dead specialty. It's a 19th century specialty in the 21st century. Our knowledge is expanded so much that I can hardly keep up with the orthopedic literature, let alone the subspecialty literature. And I think the money is best spent elsewhere, on nurse practitioners, on quote-unquote physician extenders. If it were up to me, I would make the pharmacy the community health care center linked with a small hospital and with doctors' offices. CVS is very innovative. CVS is extremely tactical. Walgreens is strategic, but they're having difficulty acting tactically. That is to say, CVS is tied in with UCLA, and they're working on a pilot project where they interchange information. The pharmacist, to me, is critical. I know what drugs I use. I know what their interaction is with most drugs, and of course, as we all know, if anybody's on a MAO inhibitor, it's E, all of the above. You call the pharmacist. But there's no reason why a pharmacist can be in control of that 9% of the cost and be part of the team. It's crazy not to be. It doesn't insult me as a practitioner. I'm not a pharmacist. And frankly, it's one less thing I have to worry about. So to me, if you fill a pharmacy with nurse practitioners, get rid of the pool toys, which is euphemistic for the retail nonsense, okay? And have the pharmacist in control of a subset of people, a couple of thousand people, figure it out. That pharmacist is responsible for the health care and the pharmaceuticals of that individual. You're talking about $250 to $300 billion a year with tons of waste and tons of overlap. You know, you heard a real interesting principle, to me is critical. Dr. Burrell called it upstream. I call it front loading. Think about what you can do as the keystone contact point in a community for primary care. And that's my challenge to you.
Brooks, can we get questions there? Question, okay.
Monica, Burrell, or tell us more about what role the pharmacist play in terms of the medical home situation you're talking about. Like, for example, what they're doing now, and then what you see in the future, and then maybe any concerns about sequestration of coming.
Can you say the last part one more time? Sequestration. So I think in terms of what can be done in a medical home, I think all of these points are pointing to the same issue around integration, working together. I can't tell you how many times I am talking to a patient and this whole, it sounds so simple again, this issue around med reconciliation, whether it's when I'm on the hospital team and it's a Saturday and we can't get the med list, but it does include an MAOI inhibitor and that's why the person's acting the way they are, or whether it's in an outpatient setting where somebody's on, their list includes 7 different antihypertensives and they're not sure which one they're taking, if any of them. So I think that, to me, the key role that you can all play in the medical home is around being an integral part of the team. Again, whether that's virtually or how that's done, I think still needs to be figured out. In small pilots, there are pharmacists who round with medical teams on the inpatient setting, and it has been shown to decrease readmission rates and med errors at discharge. There's pilots like the ones I spoke to that we're doing with the pharmacist is integrally involved in case conferencing for patient-centered medical homes. So I think there's lots of opportunity there. I don't think that your skills are being, I agree with what's been said around your skills are not being used as they should be right now. And I think a part of the retail pharmacy, to me, I think you called it pool toys, but the profit side versus what's best for the healthcare system, I think that needs to be re-examined.
But, the profit side of the pharmacy and what's best for the healthcare system are the same thing.
Maybe.
No, they are. They really are. Most of the profit is made in the prescription part. The
That's right.
idea of the front is to bring people in to use the prescription.
So we're in a room full of pharmacists. You can when I talk to individuals who work at these, pharmacists who work as these, they talk about I'm trying to think about how you could intervene with a patient in a more meaningful way when there is a certain sense of having to rotate through and fill a certain number of prescriptions. But you all are experts in that.
Yeah, I guess what I'd say, I think there is some live experimentation going on different places around the country, proving out how to use pharmacists in a sort of clinical pharmacist role. I'll give you one quick example, and it may come up in coursework or discussions here. So Community Care of North Carolina is basically the state Medicaid program in North Carolina going back 10 years ago or so. Initially prompted by Diabetes Care, it created a network of primary care practices, and they started paying a care coordination fee to these practices, but basically told them that they wanted meds managed and they wanted creative use of pharmacists. And what they allowed 1,000 flowers to bloom. They basically said to the practices, you figure out how you want to use pharmacists. So some practices have directly hired pharmacists, brought them on staff. Some practices have formed little networks where they have clinical pharmacists ride circuit. In some cases, they just contract with the retail pharmacy down the street. Whatever works. And of course, North Carolina's got, it's everything from really rural mountain practice to inner city urban kind of practice. So that stuff is happening, and that's the kind of thing that we need to accelerate and prove out. The other thing, though, I would mention is it does seem to me that we do have to try to keep pushing on what ought to be standard of practice. And so, one example that I think is valid, which is, and things I didn't know until I got into this. So it wasn't until 2006 that the Joint Commission, which accredits hospitals, made medication reconciliation a accreditation standard at hospitals, which when you think of it is a little alarming, and then they had to suspend it because it was just so difficult to do. So many hospitals went back to them and said, we can't do this with the system the way it is. So we've come a long way since then and so on, but it's things like that. Should meds be automatically reconciled at key points, in the process? How fast can we drive to having really accurate real-time medication records? So I'm sure folks at Boston Healthcare for the Homeless, you're calling around, you're still relying on faxes. It's just sort of crazy. If you follow the patient home, half the time you're finding this stuff in the medicine cabinet on the counter that you didn't know about. So that level of slack is still out there, and part of that has to be addressed by just sort of raising what the standard of expected care is, I think, throughout the system.
Yeah, if I were a pharmacist today, my future outcomes in whatever endeavor I
were involved in would be the following. One, 100% appropriate utilization of medication. You know why. Mr. Hubbard told you why. One, decrease the number of medications that people use. Call the doctor and say, hey, this person's on all these medications. This doesn't make sense because this does this, the person. Now, if the doctor is smart, never mind standard of care, never mind best practices, whatever they are, the smart doctors can say, oh my goodness, that's great, terrific. Tell me what I need to do. And if we can ever figure out how to get computer systems to talk to each other, it becomes a virtual thing. And I think that's going to happen in the private sector before it happens in the government sector, for sure. The third thing is you need to decrease the amount of medication overlap. You need to decrease the number of deaths by medication in hospitals. In 2000, 7,000 deaths were reported by medication errors, but only 14% of the hospitals reported. And that goes to front-loading the admission process in the hospital. That's a whole different discussion. And you have to show that there's a cost decrease. Those four things are really what you need to do. That's what I would glean from this talk. The question is, how do you do it? How do you put the stickies up on the wall? It's up to you to put the stickies on the wall. You had a question?
It's just another barrier that I was thinking about, because I currently work in Walgreens, and they have made a push towards MedReg and comprehensive medication review and medication therapy management. As you said, cost-effective medications, underuse, overuse, all of these slew of problems that we do see at the pharmacy level, and we are pushing towards it. But another thing that kind of came to mind was just the barrier of the patient and the fact that they're not educated in knowing that we are capable of handling their medicine. So while I see that this is a push that needs to be made, and I agree the patient adherence, all of this, but if the patient isn't willing to, I don't know where the patient education starts, and when and how we're going to make them understand.
Go ahead, you can comment first. I didn't know.
So I think that's the crux of it in this. Mr. Hubbard talked about patient activation and getting patients engaged, and I think still there's a traditional approach of patients going to a doctor's office to get the information. So I think part of it is my own profession saying, we need to partner in different ways, and how can we help each other? But part of it has to come from that angle, but I think there's a lot of outreach you can do on your own as well. You probably have a comment on that.
Yeah, I think that's major problem, and patients don't know about medication therapy management, and big thrust of the recent changes in Medicare around the drug plan is to try to create more prompts, essentially, so that patients are aware that they have a right, this is a benefit, they have a right to go ask about it at Walgreens or Rite Aid or CVS or something like that. And it just needs to be more awareness all around. I gave a little presentation a couple of weeks ago to an audience that was mostly hospital people, and I asked them, how many of you know about the Medicare MTM benefit? And one hand went up, and I thought, well, we got to cross the streams here between the physician side of the house and the pharmacist, practicing pharmacist side of the house. So I'm not surprised to hear that. Yeah. What is this about? Yeah. What are you doing? Yeah. Right. Yeah. Exactly.
Well, the solution I would have to that really revolves around one word: pain. The physician needs to understand that the pharmacist is a member of the team. So it's an education of the physician, and if you're going to have the accountable care model, if that's your preference, then the physician's payment is going to be tied to medication use. And so it's very simple. And on the patient side, you don't follow your prescriptions, you don't do what you need to do, guess what? Your premium's going up. And if you can't afford it, that's just too bad. It has to happen. I'm not talking about the homeless population. It just has to happen. I take 7 medications, okay? And I hate it. But I have a box filled up, and every day when I go to the bathroom, there it is. And I take it. I don't know what's difficult about it. And if it becomes painful, in other words, if there's a penalty, then people are going to comply. All of a sudden, instead of the medications next time costing $50, they now cost you $100. There's a $50 penalty on your next purchase. That's easy to do. And if people don't like it, well, that's just too bad. Because you're asking me to pay for your behavior. And that's not right.
Dr. Brooks, you make a
One more
great-
question.
You make a great point. I was going to ask you, you hit on it earlier, skin in the game. And there's the big piece with these health insurances. And I think we were just touching on it now. If I'm a smoker, if I'm not taking care of myself, why is my premium high? Just the same we see in the car insurance industry. If I'm a reckless driver, obviously my premium is threefold. Why, your opinion?
Well, my opinion is, if there ain't no pain, there ain't no gain. I mean, I even think, now, I'm not sure about the homeless population, because that's a very special cohort. But there are things that can be done. I guess the issue with homeless is you need to get them in a home. And once you get them in a pattern or an environment, that might be able to be introduced. But you know, what's interesting is that Uwe Reinhold, who's the guru of healthcare at Princeton, who was involved with Mrs. Clinton's initial thrust into the healthcare world, he says, and he wrote a paper, that there's nothing to prove, there's no study to prove that if people have to pay a penalty or if they have quote-unquote skin in the game, it improves costs. Now, that's the most ridiculous statement I've ever heard. And if anybody's dumb enough to fund a study for that, then they don't know human behavior. And I don't know how he can say that. We have to figure out, politicians will not do what's painful for the population. They won't do it. So the insurance companies are going to do it, and they're right. In my opinion, they're right to do it. If you don't want to take your medication, fine. Don't ask me to pay for it, because you're asking me to pay for it. It's not even a question whether it's a right or it's a responsibility. It's not my problem. You're making your problem mine, and it's costing a fortune.
Okay. We'd like to thank the 3 speakers that did an excellent job. We have one chair at the back, so please take as much of the pizza and soda as you'd like. Thank you. Thanks very much for coming.